Gerry Gormley. So I'm a Professor of Clinical Skills and Simulation here at Queen's University Belfast. I'm a clinical academic, so I'm a family doctor, a practicing family doctor. And I have been through the whole curriculum. I've set up clinical skills, I led primary care teaching, I led assessment, developed a research group. Now I'm back to clinical skills and simulation. So I've done a big wraparound, a educational delivery. I'm of the era where OSCEs were any family and friends could be an SP, to actually the very professionalised work that our colleagues are doing with regards to OSCEs. That's us. Okay, what about you? Would you mind just sharing us, just your name and where you're from and your experience of OSCEs?
So my name's Sarah. I'm a clinical teaching fellow in Nottingham at the Queen's Medical Centre. I'm a paediatric nurse by background, and I kind of stumbled into medical education about 2 years ago.
I think probably many of us have stumbled into various curricula, but
And mainly involved in clinical skills and simulation. And so I kind of had my first experience of being an examiner on a lot of the final year OSCEs and CP1 OSCEs last year. So I've had a steep learning curve, but I'm really loving teaching and medical education.
Oh, thank you.
Hi, Andy Buttery, Regional Simulation and Human Factors Lead. I was in Nottingham for about 15 years doing simulation full-time with Frank Coffey and Bryn Baxendale. So I've done a lot like that. I've spent a lot of time lying on a bed with a male catheterisation model, experiencing a traumatic catheterisation at high volume.
And I'm trying to unsee this now, and it's not working.
I have the video available and counselling sessions booked.
Okay. Yeah, that's for this evening. Thank you for sharing.
I'm Catherine, I'm from Hull. I'm a clinical teaching fellow at the Holyoke Medical School currently. So I've kind of delivered like mock OSCEs as a foundation doctor in a more sort of preparation style, but I will be probably involved in more of the summative OSCEs this year. So.
Yeah, and everybody comfortable with the term formative and summative. So formative, the essence of feedback, but summative, it's the yes, you can progress or not yesterday. Thank you.
My name's Craig Osborne. I'm a final year medical student at the University of Aberdeen.
Sorry for interrupting. Somebody's obviously got invested interest. So, by chance, do you have an OSCE coming up soon?
In May. Yeah.
In May. Okay.
So the vast majority of my experience is being assessed rather than delivering OSCEs.
Sure.
But as students, we do often quite like to prepare OSCEs for each other.
Yeah.
Because that's the best way of revising.
We've all had stuffed pillows up our jumpers for examining the pregnant abdomen. We've all been there. Yeah, but thank you. Can I go to this table?
Alan Platter, I'm the simulation lead for Northumbria University, I'm a nurse by background. And really, here because we do OSCEs kind of mannequin based patient simulators, we do use simulated patients. But in the change in the curricula, massively going particularly in the third year to using standardised patients as OSCE. So been doing that postgrad, but how does it kind of trying to get the numbers in my head about doing 300 to 500 students with a standardised patient in an OSCE.
Yeah.
So I'm here to absorb.
Do you know, funny, I saw several heads in the periphery of my vision going, we feel your pain. We've been there. So, but thank you.
Hi, I'm Ursula Heaney. I work in the Western Health and Social Care Trust in Derry. I'm a clinical skills nurse up there, have been for about 10 months with a background of AT nursing for many years. We facilitate final year mock OSCEs, and we run them for all the final years. We also have Queen's come and use our centre for their official OSCEs, and then we also have peer assisted learning programmes in place where we advocate our fifth years to provide OSCEs for fourth years and fourth years to provide OSCEs to our third years.
Yeah. I think I saw a few heads. I think that's probably and similar during where actually some of your students are actually. They said you've never actually delivered an OSCE, but interested if students are starting to do that. You know,
I'm Paul Martin. I'm a registrar based in Belfast. My background is holiday here in pediatric. In terms of teaching, I'm an HLS instructor with a side to do the OSCE sessions at Queen's, so I'd like to find out just a little bit more.
Okay. I'll see you soon. Okay.
Hi, Laura McKenzie from the University of Illinois Chicago, and I come to this medical simulation via theater. So my background started out as a standardized patient, and now I work with the standardized patient program and run several OSCEs as part of our both formative and summative.
I was in your institution last year. I spent some time. It was lovely with Walter and that. So in the area of Chicago.
Mm-hmm.
Julia Fowler, I'm a teaching assistant at University of Glasgow. Again, just much the same programme changes and increasing student numbers. It's looking at how we can adjust our summative policies.
Okay, thank you.
I'm Linda, also Linda. You don't meet very many young Lindas. Linda's from HR, but anyway, I'm Laura from the University of Illinois Chicago. Same thing, we started out as standardized patients and worked our way up through the ranks. I'm now a standardized patient coordinator, and a majority of my responsibility throughout the years to work with the graduate medical education OSCEs over the different disciplines.
Thank you for sharing. Last but not least, this table over here. Do you want to?
My name is Vicky Adams. I'm an academic surgeon in Belfast here, so essentially the worst type of dentist. And we have various OSCEs for the undergrad dental students starting in fourth year and working their way right through the final year. So I'm various involvements with those in different ways from organising to being in station.
Can we go this way?
Sorry to be late actually. My name is Neera. I work as a clinical educator for King's College Hospital. For King's College London students, I'm not here to get a lot. So I do quite a lot of OSCEs, formative and summatives, starting from year 2 to year 5 all the way through. So that's one of the reasons for me to be here as that. And also I'm doing my thesis on OSCEs and perceptions of year 5 students' OSCEs. And one of the questions and one of the answers quite a lot came through SPs and how can we standardize their practice. So, it would be nice to really get some
Question as well. Lovely.
I'm Melanie Humphries. I'm from the Birmingham City University. I'm a faculty lead for skills and seniority. So I have a varied and wide insights into SIM, faculties, health, education and life sciences. What I want to achieve from this workshop, I want to achieve the title, but I'm mindful I have to leave at 12 to catch a plane.
Okay. No pressure on both sides.
Enhancing the authenticity of simulated patients in OSCEs, which is what I'm here for. So yeah, I've got experience of support in running OSCEs, different curricula.
Thank you.
My name's Andy. I'm the Sim Tech for Clinical Education Centre, so I would be involved in the OSCE preparation of international nurses.
Got it. Okay. Thank you.
Hi, my name is Graham Devine. I'm a nurse educator. I also work in the Clinical Education Centre in Belfast. I have a bit of experience in simulation, and as Andy said, we run an OSCE preparation programme for our internationally recruited nurses.
Hi, I'm Karen Reynolds, manager of the Interactive Studies Unit at the University of Birmingham. We are primarily SP team, and our SPs work on the OSCEs for our students across the different professional courses that we run. And I am here just to maybe learn a little bit more about improving what we can offer.
It's just your name, your favourite sports.
Where
are you from?
My name's Lee Green, and I'm a senior lecturer in simulation-based education at Manchester Metropolitan University, and involved in OSCEs for advanced
Thank you. And that was really important, I think, for us, but also for you guys. And I think one of these notions that we think the OSCE is a very unified form of assessment, but actually it varies from discipline to discipline. Also, when I look at the OSCEs we do now compared to 10 years ago, I cringe at the stuff that we did, that we were trying to recreate an authentic experience. I mean, we had, forgive me, Paul, but we had professional actors, with, yes, I've got chest pain. No, you don't. You don't portray that. So, and also for many of us, okay, I am a GP, but reflecting for those of us who are healthcare professionals, often just didn't reflect the world that I work in. Yet we know that OSCEs is a big driver for learning, okay, and particularly behaviours. So this is really kind of our stance, is that that OSCEs are a very powerful learning tool, but if we're mismatching this to give a synthetic, artificial experience, and then they have to do something totally different in the real world, that troubled me, and that's really where I thought we could try and pull in some experiences from this really rich field of simulation to try and narrow that gap, improve the authenticity of the way that we form and assess our students. So what we're going to try and do in the time remaining, and some of you have only 15 minutes, is that I'm just going to pause for a moment and take you through the life cycle of an OSCE, just to get you to think about it, okay? And I think this will hopefully convey the professionalisation of OSCEs, the professionalisation of SPs. It's getting really sophisticated now, so we need to think about the steps around that. And then we're really going to just dip in to some aspects, and you'll see a lot of performativity drawn upon the performing arts around how we can maybe enhance some of the OSCE experience within our students. So this idea, we're going to go one station at a time, so it is going to be like a formative OSCE, there's going to be no bell, and we're going to get you to talk and think and share. But most importantly, we want to create a safe space for talking. This idea of critical friends. We want to be able to people to share ideas freely, but also gain something from it in a friendly manner. So that's our agenda for this session. Does that sound like a plan? Yeah, is that okay? Assessment. Let's just step back and look at assessment. Assessment methodology research has really blossomed and exploded over the last 5 decades, and there's lots of forms of assessment. Again, what's the best way of assessing competency in an individual? Does anybody have an idea? Is there an ideal ruler out there that we can measure an individual and how? Of course, there's not. It's not right. So it's really about multi-method, multi-assessor, and ideally over a longitudinal period of time. You're sampling as much as you can to get a profile, to build a schema of the abilities of this individual. So there are many. I mean, do you recognise some of these assessment tools? OSCEs, case-based discussions, mini-CACs. I gather there's over 60 methods of work-based assessment, and they've all got these fancy acronyms. Okay. And when we pull this together, we want to make sure that we build an overall profile in assessment. You've heard of Miller's Triangle? Yeah, so this kind of conceptual framework that we want to know, do they know the knowledge, do they know how to apply the knowledge, but then more in the behavioural, can they show it, and then can they do it in the workplace? And that's where we're kind of putting our attention into, is the behavioural skills. So the OSCE, 1979, Dundee, Ronald Harding and colleagues created this new format of OSCEs. And of course OSCEs is right across the world, right across the disciplines. We have nobody from the veterinary sciences. We were talking to somebody on Monday. Yeah, they do OSCEs. And I've seen one. Plastic animals and long gloves and things like that. And of course, police and many other professions do this structured form of assessment. If you look through the research, it's interesting some of you are doing research on OSCEs. OSCEs have changed over time. And if I said to you the post-psychometric era, does that mean anything to anyone? So if I said to you over the last 10 years that our psychometricians or statisticians had a real dominance in how we shape our OSCEs, they want to get precision. They will look at the numbers and tell you, that station's no good, drop it. But actually what I was hearing from my OSCE examiners, that really tapped into behaviours. We are really thankful for our psychometricians to help us getting a really reliable OSCE, Crowsback Alpha and all these sort of stats. But we're starting to gain this ground now of actually want to make sure what we're assessing is what is reflected in clinical practice, the validity of that. And a lot of people have spoken around this, that sometimes OSCEs maybe just don't do that. And again, it's your OSCE. You'll all do OSCEs differently. It's making sure you shape that from your own style. So I'll just acknowledge a little bit of conflict of interest. So I was part of the panel that developed this new assessment called the CPSA. For those of you in medicine in the UK, so medical students in the year 2023, what was on the table that all students will do the one OSCE across the UK. That was rapidly taken off the table. Okay. So what we have done is we're driving key performance indicators on how the institution develops and enhances their OSCEs, that it's constantly improving and quality developing. And medical schools are now mandated and encouraged to, first of all, acknowledge the work of our SPs, that they're supported, they're developed, they're properly trained, quality and diversity, but also the need to make sure that we represent authentic patient experiences. So this is the first time that I've seen in policy documents and assessment in an undergraduate arena really pushing forward on this idea of tapping into authenticity and also the acknowledging the work that we with our SPs. So there's a real drive for this. So for those of you who work with medical schools, you will start to be preparing for this and building on the work that you're already doing now to make sure you meet those key performance indicators. Is that new to anyone, or if some of you recognise that? And our colleagues who from outside medicine, do any of your colleges have any, or regulatory bodies have any thoughts around that? Or so.
I'm sorry, did I laugh out loud there?
Did you?
Yeah. Don't open this can of worms on this main.
Okay. Well, I just keep that can slightly, just unloosen a little bit. I'm certainly on an international arena. I haven't seen this before, so it's an interesting era. I think that we're pushing forward. Yeah. Okay. So we're going to start to take you through the OSCEs. Does this remind you of any OSCEs? The idea that you have a OSCE examiner who's the critic in the audience, the student rushing around trying to tick all the boxes on the checklist, and then we've got a patient who is the patient a person or a prop. So those are the things that you probably get a sense that we're going to delve into a little bit deeper. Okay, take a breath. That's OSCE Station 1. I'm sorry if that was a bit sort of didactic, but it's kind of just to get you a little bit of an even kill on the background of OSCEs. Here's the life cycle of an OSCE. Okay, do you know when somebody says, "Can you write an OSCE station?" Yeah, I'll do that. Did you realise the work that you're about to do over the next several months? So when you have an OSCE, you have to make sure you've got a blueprint. What are we assessing? That's in a systematic sample way. There's that feasibility check. Yes, we would love to use SimMan or Harvey, but we need 7 of them because we've got 7 circuits. Do we have that equipment? So just let's do an initial check-in. Okay. Another thing, for example, who here would work with SPs? Oh, you guys are, yeah, okay. Internationally, we realise that the demographic of SPs tend to be more skewed to older professionals, but that's changing. Okay. I will admit, at a time in our medical school, that we had SPs, and we would, for example, the clinic with this station needed to be an SP of a childbearing age. We pushed the limits. We pushed the limits on that SP. So it's the feasibility check. Have you got the resources, potential, and relevance? You've got to make sure you've got the assessment objective. What actually are you assessing? For example, if I say we're examining the precordium, examining the heart, yeah, we ask our first-year students to do that, but also our final-year students. So the question is, what actually are you assessing? Is it the process? Can you put the stethoscope in the right position? Or for a final year, can you get the process right, but can you actually detect the murmur? Okay, so it's really getting down to the nub of what you're actually trying to assess. And then you pull all together those candidate instructions, the examiner instructions, all those various entities. Okay, I don't know, has anybody here written an OSCE station or 2? Yeah.
It was for an assignment, so it wasn't.
It was for an assignment.
Yeah,
okay.
It was put upon me.
Okay.
But it was a really tough process.
It's a tough process.
Really tough.
It takes time. It doesn't take an afternoon.
No, it really doesn't.
And you said you've written some stations.
It was a while ago, and it was probably closer to when we got a lot of things wrong, Gerry.
Yes, I know. Certainly writing an OSCE station of our OSCEs can take 2-3 months. Not constantly, but coming back to it, getting feedback and constantly refining. Then you got your first draft, you got it piloted, is it readable? Have you got the kit, does it work in the time? Have you thought about students who have got special requirements? For example, dyslexia. Does your one page of instructions contain 60 lines? Okay, so you need to look and address that. You do your final draft and then you do your post-OSCE analysis. That's a lot of work. Okay. What we're going to zoom in now is this idea of constructing your OSCE station and drawing upon your skills as clinical educators and simulators around developing enhanced, authentic patients' experiences. In any performance, we've got actors, we've got a stage, we've got props, we've got costume, we've got scenery. We're going to start with the props. Nice place to start. Okay. So, can I get you to do an exercise? It's called Think, Pair, Share. Okay. So I want you to think for a moment of experiences that you have, or maybe would like to do, where props from the sim world could be used in an OSCE. Okay. It doesn't matter about the actual nature of the station, but any props that you have used, think about it. Share it with your neighbour, and then we'll harvest some of those ideas. So really keen to hear what you have to say. So just think a moment, and then turn to your neighbour, and have a chat. That's one of the things I like about this work. You can start to hear the rich tapestry of things that are carried out by you. I think the sim world are really good at tinkering, and that's not a derogatory comment, that's actually a technical term. It's really about experimental, creative thinking and how we can develop new ways. Okay, I'm going to have to go. Would you mind? I heard smells and I want to hear about it. Okay. So please share. And then, by the way, it was about OSCEs we're talking about. That's okay. That's okay.
I feel a massive amount of pressure now. So we were just basically saying, my university school is tiny and there's no budget there whatsoever. So, Linda knows it well. One of the OSCEs was Abdul being a patient who vomited, so we had the sick bowl and cold soup.
Cold soup. Can we ask what type of soup would you recommend?
That's fine.
It has to be minestrone. Of course! There's always carrots in. Sorry, is there carrots in minestrone? Okay.
Wait, where was the soup? Got it. Okay. And was it the smell of the soup, or did you do anything in addition to that?
No, I mean, it was just literally part of the process of trying. We have done similar things out with the actual OSCEs.
So, and again, I hope we're going to try and pull this together, but I think, hold that in your head, minestrone soup. Okay. Would anybody from this table like to share any sort of props or experiences?
We were talking about, my colleague is paediatric background, so that immediately gives you some problems in terms of SP patient. So we were looking at it in some situations, your prop is likely to be an adult SP, and in other simulations your prop is likely to be a very rudimentary mannequin.
Yes. Yes. So obviously, just recruiting children and teenagers. Yeah, I know maybe some of you are working with drama schools, but you're absolutely right. You can't subject a child to repeated examination. By the way, anybody use real patients in their OSCEs? Yes, exactly. And I'm going to come to that term.
And I was about to say my son was a simulated patient as a child, as a 2-year-old, so he was involved in CP examinations.
And I think that reflects the mood that the whole arena of SPs is starting to really diversify and professionalise. And we're going to areas that we normally didn't, psychiatry. Okay. And some of the work that it would be unethical to have somebody relive and re-traumatise, but actually capturing their experiences is important.
And I think what we were saying.
Sorry, can I just ask about? Sorry.
No, you're fine.
Can I just ask about that term, because it does generate quite a bit of debate in nursing circles. The Nursing Midwifery Council said for replacing practice with simulation, you have to use it in a kind of clinical setting, and I'm saying that in the broadest sense, on real patients, sick or well. Now that if someone's sick, to me that's real life. It's not simulation. But that intrigues me how you actually use real patients. Is that in a clinical setting, or is that actually bringing to a sim lab? Or?
I'm looking at Linda. So this is actually the focus of her PhD.
Right.
And maybe I should Linda. But you're right. It's once you start digging the literature, you know, SPs, Burroughs and McMaster in the 60s, where they were people of the night. You know, they were prostitutes. That's where SPs started from, and then it's developed the idea of simulated participants, because you know the notion now we're trying not to use the term simulated patients. It's people who have lived experience of illness, and again, illness is such we experience it differently. You've got acute chronic illness. I could have the same condition as somebody else, but I experience it differently. So it's people with lived experience, individuals, and then real patients. Is it expert patients, or is it somebody who's literally transferred from ward to the OSCE arena? It's actually complex.
That's my point. Is just trying to clarify that. It kind of becomes a bit murky about how you're using them. Again, I had a PhD student who was wanting to do a simulation with real patients in the bedside, because as medics, that's what you do. You take a bedside teaching, and she's trying to class that as simulation. So it's opened up this huge debate about.
Yeah, it is, and it's blurring the lines between work-based assessment.
Yeah.
So we would still have work with real patient individuals with lived experience of illness, but obviously we only can really recruit patients with stable chronic conditions.
Yeah.
So and actually we published that work that these students can largely predict the type of cases. You know, somebody who lives with rheumatoid hands, or somebody's got a heart murmur. You know, that's more likely to be an OSCE role than somebody acutely unwell child.
Yes.
Just gonna say, we do we have OSCEs in the earlier years, and then they progress to things with different acronyms. But
yes.
we then sort of have a mixture of simulated patients and sort of real patients come in. So for the mental health station, that is always a simulated patient. And depending on the gynae station, that's usually a simulated patient, but the rest of them are usually brought in with, like you said, more chronic conditions. So it's kind of a mixture.
Yeah, and it's interesting and it's always reassuring that actually our discussions here, we're looking for direction, and actually this is a relatively evidence-free zone. So we need to start to do some work in this area to try to define the direction of travel within this in particular arena. Can I sample something from anything you'd like to share from this side of the room of like props that you've used and also use on OSCE side? This is a phenomenon in Northern Ireland. It's all, go on, you go on, who are you? Ladies first.
We were a little talk about our medical emergency ones, and just it's kind of basic props that we use in it. It's we use fentanyl, we use TTN, and use with simulated patient to be careful. I don't know if we require any of your team, as they spend most of their time unconscious, not speaking to anybody. And there's about some props I would like for it. But I was wandering around yesterday trying to see if anyone, but if they don't seem so, I would like a carotid pulse that you could put on a simulated.
Okay. We will talk later. I'm sure those can maybe give you advice,
People can kind of affect the respiratory rate, but can't really affect the pulse rate.
Okay, well, let's see what we can do. But also from the arena of dentistry, obviously a lot of your assessment would it be on mannequin heads?
A lot of our we do it without any monitors, because most dentists when they go into practice don't have any monitors, so a lot of this physical clinical assessment.
Got it. Can I thank you? And just if you wanted to share one, I'd love to hear.
No, just in relation to sort of real people, we have a station which is particularly focused on nursing assessment, so we would have to have real people there for that, because you're really focused on communication, the interaction with the patient. And you just can't get that from that.
Sure. We're going to come back to that later about the script. And they also, who writes the script? Should you have a script? This idea that OSCEs be very digitized. I remember the time when we wrote OSCE scripts. Student would say this, SP would say that. Does that reflect the natural ebbs and flow of conversation. It's the Walter's talk today. Communication is very nuanced, but actually we want this rigid, digitized, synthetic conversation. So, but I love that. But real patience. That's the way that we work. Can I give you some of my ideas? Maybe that might spin off some ideas with yourself. So, I feel like I'm airing my dirty washing. Yes, we did this station for a number of years, suturing on a pad. There is a game show in the UK called the Generation Game. It's kind of against the clock. How quickly can you do something? And I bet it was comical. You know how fast you could do this on a bench, and there was 30 students. So why not just use some hybrid simulation? Okay, I'm sure we've all done some aspects of this, where you're not just suturing, you're suturing a patient, an individual's wound. And you know what? Look at the assessment opportunities here. For example, if the SP was instructed to say, ouch, that's a cue to say, stop what you're doing and put more local in. Isn't that a really important thing to want to students to do? You could ask that. What other things you could ask the SP? So while you're doing that, how should I look after my wound? When should I take the sutures out? Let's put a bit of glass in that wound. And I'm sure you can think of others. Okay. So all of a sudden, you're starting to assess the technical skill, but also all those other really rich, important skills that wrap around this whole process. Okay. Does anybody do this sort of hybrid simulation? Would you love to? Can you share an example just to? We know about the catheterization, and I'm still kind of that.
So we have trackies that we attach to stimulate patients. We've got scars, and it's interesting that you were talking about the scripts. So I work in the Northwest, and we have a simulated patient program that we deliver through Health Education England, and we teach people how to write roles. So our simulated patients in OSCEs and in general simulation will come with an idea of who the person is, and they'll be able to answer questions and put in those prompts and cues as part of the role that they're portraying, rather than just simple student says this, I answer in this way, so that it's a really authentic representation of the character.
That's really fabulous to hear about the authenticity and trying to tap into that. Also get the sense we all are gravitating this direction. We realise that OSCEs are what they may have been, but be what we want to be.
I just we had a brilliant one where radiographers were doing a range of stations on IV competence, really. And in one of the stations we had an SP with an armband on, and they had to give an IV drug, and that was all they had to do. But there was a number error between the armband and the treatment chart, and the number of, because they knew the objective. The objective was to give the drug. So they go, there's a number, it doesn't really matter. So pretend.
Yeah. So all of a sudden you can see the potential variations of assessment and actually starting to get nearer to what we see in the real world. Lovely. For the interest of time, I'm going to move on to some other things. Administer an IV, so just track up a tube, collecting the pot, you can do 50, in this repeated industry sort of type fashion of an OSCE, we have to do lots of assessments. So, given the IV and it just collects in a bag. There is a story behind this. And again, my dirty washing line is getting really full. But we realised that in OSCE we've never had a breast exam in an OSCE. And this is about 15 years ago. Terrible. Absolutely terrible. So we went to the simulation catalogues there. Actually left one at home. I've got small children at home. It's like, no, you don't look at that. So we bought this. How much do those mannequin prosthetic breast devices cost? And this was about 10, 12 years ago. So £700. We needed 7 circuits, probably a backup as well. So we thought, this is great, we're going to do them. So then we got them, and then I suppose there's a kind of a cultural influence to what we did in Northern Ireland. What do we do with these things? Do we just leave them on the bed? What do we do? So we put them on our SPs. However, you know what's going to happen. One of our SPs didn't turn up, but we had a backup SP. But there was a gender. So we had, I can remember his name is Frank. Here. My name's Mary. And I've but actually, But where this story has directed to is where we are now is actually our SP community said, look, we'd be happy to do this if you support us.
Yeah.
So these are now in the cupboard. In fact, we're throwing them out. They've dissolved. So it really shows about working in partnership with your SPs. They have a real vocation. They want to help, and why work with them? You talked about work with SPs. So I think it's important. Why not work with patient groups? Have co-writing station. Okay. And then there's a whole array of technology, the ventriloquiscope, sounds that you put on the SP, and the sounds vary, and that's okay. So and I'm sure there's many others, but just to get you think about some of the props that we use and how we can do that. I'm going to hand over to Linda. Linda's going to take you through my badge.
So we moved on to the fourth station, and in the interest of time, and obviously you want to hear Paul speak in relation to the script as well and our SPs. So than doing maybe the think, pair, share, maybe you could just shout up some ideas and some stuff that you actually use within your sim centres or your clinical settings or whatever that you do, preparing your scenarios for OSCEs in relation to Millage or special effects. What kind of things do you do at the moment to prepare the scene, set that scene for your students, get them to buy into them, to stay off that actual scenario? What kind of things do you do? Yes, thank you.
In one of our GME, graduate medical education OSCEs, we have an elder abuse case.
Oh.
And I'm fortunate to have some wonderful senior citizen SPs. And before we have, the woman is in a wheelchair, she's had a stroke, but we also have to place bruising on her as if somebody grabbed her roughly in her wheelchair. And there's an abrasion around her leg where she's been tied to the wheelchair, and so it's a process to get her ready.
Yeah, indeed.
But they're very realistic looking and convincing.
I was going to say very powerful as well for the learner to actually see that and visualize. And do you do them up, or do you have a?
Yes,
you
learned how to do
it
excellent. On the internet. And
but it's just to come on.
Yeah, no.
It looks obviously a very visual cue. But as a healthcare professional, is when I see that bruise in practice, the emotional I'm going to have to open this up here. So we might say, it's great to do that, but actually the emotional landscape that you're creating with that is phenomenal.
Yeah. It's so powerful. So I hadn't done any kind of that kind of simulation before, and I was asked to help out on our final year students' healthcare of later life, and there was a patient that had been abused, and I just came into as observer to observe simulation and how we do feedback and debrief. And I found because it's not my platform, paediatrics, I don't come across that. I was very surprised at my emotional. The SP was amazing, but the bruising, and I was quite overcome emotionally afterwards. And I just thought, wow, that's really powerful.
Mm-hmm.
This is not real, but it felt so real. In there, watching the students deal with this, and then uncovering the whole scenario was quite emotional.
Yeah, no, indeed.
Yeah.
And probably another discussion is probably the safety of the learner as well as the SP who's portraying that and those all involved.
Yeah.
I know that's probably another discussion than what I'm covering here. Anything else that anyone else uses in Millage or... Yeah,
well, on
keep going.
a lighter note,
Okay.
doing dermatology.
Here's a list.
A little bit lighter. It was a dermatology OSCE, and the dermatologist, I was working with one of our doctors, and she wrote all the cases, and she did all that work. We piloted it, all of it. But one of the cases was the patient was over tanning, using a tanning booth, so I couldn't ask somebody to go get tan, so we bought a bunch of bronzer, and she would just cover her arms in this dark
Saint-Tropez.
And they got paid to get this done.
What's that?
And they got paid to get this done.
Brilliant.
But it created the effect because she was, basically a fair-skinned individual.
Yeah.
It looked like she had spent too much time in the tan booth.
Good. Anyone else?
I mean, for some of the cases, it's just how the patient presents themselves. Are they disheveled? Do they look like they just rolled out of bed? We have a manic case where if it's played by a female, she has to wear way too much makeup, provocative clothing, bright colors. might have a bunch of magazines that she flips through at some point. We've used heating pads for like knee joint so that the SP puts it right on their knee right before the student comes in to have like a warming effect.
Oh, that's very
Yeah.
good.
That's
Yeah.
really,
Yeah.
because we experience the world through our senses, and it's not just physical, touch, what we see, it's what we feel, what we smell, but also the temperature. And again, that idea of touch in healthcare, it's a real fine line. We shouldn't do it, but actually, most times when we're patients, we're touching.
Just to add to
Yeah,
this,
no,
we
please
don't
do.
do it with OSCEs, but to help our healthcare assistants in immersion, our SPs come and let them be washed, and they have leg bags, and we add to the urine some tuna fish juice to give it a bit of smell. It's a bit
Lovely.
Oh.
I love this way healthcare
I love
is going
this
to
idea.
infection with food. So the take home is going to be minestrone soup and tuna juice. Can I add to that? We had a head injury station, and one of our SPs, as a clinician, if I smell alcohol, it's starting my diagnostic process. So we had a little atomizer and spread some whiskey. One of the students, one of the students came in and
No, you're fine.
I can smell
This is shared.
Jameson's. It was Jameson's. So we did a page questionnaire after that. And just
I think as well, be careful with that as well. Obviously, bringing alcohol on purposes and
Yes, I know. Not that drinking, but you'll smell alcohol. There's all those.
That'd be great for professionalism as well.
We've done that, but not such expensive. Usually as design.
Yes, yeah. It was what I had left last minute. Sorry, you're getting 2 minutes.
Sorry, you were
We
going to
run
say.
an unconscious bias simulation where two rooms are running the exact same patient but presented in a different way.
Okay.
So one smells nice of deodorant and aftershave, and is presented his suit's hanging on the hook of the wall. The other case, we empty all the ashtrays in the university from outside, and we have alcohol, and we rub dirt and all sorts. We kind of go into the gardens and get milk, and he has a bag of clothes. It's exactly the same case, but presented with two completely different patients, but the physiology is exactly the same. Interestingly, every time we've run it, the students have not flinched at the smell at all, and it is revolting. It is stomach churning.
That's
and they are so
like that.
professional.
That's kind of for Merleau-Ponty. It's this idea of phenomenology, how do people experience the world, and it varies. And just this idea of it's not just the physical sense, but it's distortion. We have a centre here in Belfast, right on it's the youth justice system, where it's a it's like there's a train, there's a shop, there's a prison cell, the big prisoners inside you. This is what life. But they also have fire safety. They have a room, like a teenage room, and it's all these devices and electronic adapters and adapters. And the same room on the side is where it's burnt. And they took the window off because it broke, but it's that burnt smell is the one thing that everybody remembered. So that idea of that's smells, memory, in industry.
I'm quite conscious of time, and I know Paul needs to speak as well, but this is really good to share some of these ideas and be open with them, because it's really handy to know some of these things and tips and tricks, and some of the ones obviously we've come across. This is Gerry looking at his and then we've developed melanoma tattoos, and this has come from actually Gerry's son that ended up having one of those transfer tattoos. And then he came up with the idea that this would be something that we could apply to our SPs, and obviously buying that wheel is an authenticity. But you had a scenario where the SP went away and still had the tattoo on, wasn't it?
Yeah, we've been doing this for about 15 years now, and just we had an SP after the OSCE had a melanoma tattoo, and the SP went for a swim, and he said, the SP came back and said, Gerry, I need to tell you the story that somebody approached me in the change rooms and said, look, I hope you don't mind, but there's something on your back, you can check it. And he said, look, this is something that I this experience. So actually, what we have done now is with this idea of simulating patienthood. We actually have a study where we actually got the students to live with this for a day, and it just opened up all those nuances that patients with cancer maybe never can truly recreate. They think attempted to step into what it's like to have experiences. This idea of transmission, people don't want to say you, so they avoid you. How they make you feel. So it's so interesting. And here these tattoos cost less than a penny, but they
And then obviously abrasions and cuts and moulage like that, I'm sure you're all quite. And I'm going to let Paul.
Sure.
Are you going to say something else? Are you doing something?
So I'm conscious of time,
Yeah,
and it's lovely hearing the rich ideas, and I think that's really what the workshop is about, is sharing your ideas. And we've talked about the props, we've talked about the makeup, moulage, but now about costumes and scenery. I'm just going to give you a little sort of essence of some of these, because this reflects some of our typical OSCEs, in our clinical skills centres. Several people decamp their offices, so we use that as a station. And again, does it really evoke a clinical scenario? For example, is this supposed to be like a GP surgery? We call it GP surgery, GP office, family physician. So thinking about the environment, I told you about that actor who had the professional stance. Okay, just, bit of water with glycerin, sweat, incessant beeps, the oral, the auditory experience, those needs are just tucked underneath the pillow. Just gives you that essence of, you're in that zone. And then this is some of the work in mental health simulation, and this rich arena where we actually got our drama students to get into the narrative of the story, which Paul will talk to in a moment, and let them create the scene. And I think those scenes create a very evocative moment. I always remember this scene where the SP was locked in the shower room, and this was actually in a theatre, actual performance theatre. We just used the spaces.
In fact, we used every space except the theatre.
We didn't actually use the theatre. And so the GP trainee and the social work trainee were about to do the scenario, and they couldn't open the door, and they went, the door's not open. It started, So that is essentially how the scene's not just for the sake of, it actually plays into the story, and that's important as well. And this idea of the decentralising of SIM, it's interesting to see everybody's now has their inter-SIM service. It's been decentralised. It's bleeding out into the vast arena of health and social care environments, and all this sort of thing. That's just randomly put to the side. It creates that. Paul, I'll do the script and you do the SP training. Is that okay? So we've got our scene, we've got our props, we've got our individual. What about the script? And I feel that we do create our scripts. We have to give some information, some content, and I'll admit I was at a stage where I had a very digitized script. But interestingly, when I first met Paul and his colleagues, I said, "This is the script." He pushed it aside. What's the backstory? Where's the trajectory in this story? Now, remember, this is an OSCE. This is not SIM. The power, the force of standardization. We want every candidate to have the same experience. There's attention. What do we do? Training. So you're right. This reflecting that we, SPs and this idea we use SPs. No. You don't use SPs. You work with SPs, helping them, for example, co-write with the patient group, with a station where carers of patients with dementia help us actually develop the narrative about what actually is important with this station. However, your psychometrician will still want a standardised checklist. How do we trade this off? The natural flow of conversation, but our psychometrician wanting boxes. How do we get around that? How do we square that? So, do you know what? There's no evidence. Again, this is you're on the edge of what I am aware of as the OSCE evidence and research, is that we're still in a space we don't know. However, I will give you some reassurance that this idea of what we call semi-global scores. So we have checklists that say, have you said introduction? Have you washed your hands? Have you said hello? What's your name? We're moving away from that now to more what we call semi-global scores, even domains. For example, overall introduction. Did they get to the crux of the problem and having your several check points? Interestingly, that still keeps your psychometricians happy. They still get their nice quality indicators of growth back alpha, and R-squared scores. So we actually are now moving into a space where we can now have some freedom, where you want to give a constructed idea of what the OSCE is about, but also there's some flow between that. Okay, so hard to give you a concrete answer in this, but it's moving in that direction where we, in one hand, keeping the reliability, but allowing these nuances and the ebbs and flow of conversation happen. Because we've done that in one of our stations where we just had a real patient tell their story, and the domain scores, they got to they got the presented problem, and the metrics were fine. I'm going to now in the last minute, because we've done lots of talking, so we're condensing the last bit, but actually how important is how do you prepare RSPs? Paul, I'm going to
I've got 1 minute.
You got 1 minute.
How do you turn a person into a prop?
Totally, to end it all. I'll just tell you.
You use them. I've heard people say they've used patients or used SPs 10 times in this meeting alone. What does that tell us? It's part of the firmament, isn't it? And it's a problem for me, because you don't use people, do you? Why does that term is used? It's part of the technologization of healthcare over a century and a half, right? What's the purpose of engaging in any kind of simulation? It's to achieve an effect. So if you bring in somebody who's a simulated patient, do they have to be a person who has had a particular malady, like myself, Crohn's disease, and a minor operation? And can I only perform in that role? Because that's my expertise. So I can't talk about somebody who's had a hernia operation, or who's had a tumour removed from their brain. Or can I? I think what we're looking at then is there's no fixed agreement on even the terminology. Is it simulated person, simulated patient, standardized patient, simulated participant? Yeah? These are all well and good until we look at the consequences of it. How are you engaging? I think the word engage is the best one, sure. You don't use people to engage them. It's like, can I use your pen? Can I use you? Just for a minute. Can I use you for a minute? I think all that we play for, it's part of the culture, isn't it, of how we engage with people. You don't use actors, what people say you do. You engage them to do a job. And I think the more that the culture, I think, is approached as a case of engaging with and getting feedback from. And also, a lot of the SPs at Queen's asking, can we get some training from you so that we can do a wide variety of roles? We can get more. And I was interested they would ask that. I don't elicit that. I don't recommend it. I just, put it out there, And then in response to me, yes, of course you can if you want to. So I think if I may suggest or observe what I'm witnessing as somebody who's only been 5-6 years coming into this world, is that there seems to be an evolutionary process going on. Perhaps it's been going on for a long time, about what simulation is and who is involved in simulation. For example, unless you're the student, is everyone involved in simulation? We ran some in this room, was it yesterday? Or was it a different room, 3A? We ran a simulation of a de-escalation mental health scenario, and then of an infant mortality scenario. So who were the simulated people? There was the actors, who performed the parents of the recently deceased child. Was it the doctor, the paediatrician talked to them? Or what about the people who performed the resus? Who was involved? Who were the simulated? Who were the actors? Who were the professionals? And who were the simulators? Yeah? These are more questions than anything else. I don't have smart answers, but hopefully smart questions. Because that's what we're in the business of doing here, isn't it? I could ramble on for an hour, but I have to get my taxi right now. But it's been a pleasure.
And thank you, Paul. I think there's a dramatic exit.
A dramatic entry?
I feel like myself saying encore, but he's gone. So look, again, we're wrapping up here now. Yeah. Hopefully today we've whetted your appetites, but most importantly, hopefully we've got you thinking about your OSCE and maybe some things that you might want to do different or actually experiment with and develop in your future OSCEs. I think this arena of